Dr. Rosen, I leave it to you.
Thank you so much. Hi, everybody. My name is Dr. Alexis Rosen. I'm a neuropsychologist in the Cognitive Rehabilitation Service at the Martinez VA, which is part of the VA Northern California healthcare system. I earned my doctoral degree in clinical psychology from Palo Alto University, where I also completed the neuropsychology area of emphasis. And I've had the privilege of training and working in a number of different settings, inpatient and outpatient, and with a wide variety of patient populations. And I'm really excited to be here today speaking with you all about the what, when, and why of cognitive concerns in Parkinson's disease and how to overcome them. So before we get started here, a few disclaimers and disclosures. So the contents of this presentation do not represent the views of the Department of Veteran Affairs or the United States government, and I do not have any financial interest to disclose. Here is our agenda for today. So we have quite a bit to get through, so I apologize if it seems like I'm rushing at times. There's just so much helpful information, but a little bit about what you can expect to hear today. First, we'll define some important terms that you'll hear me say multiple times throughout the presentation. And then we'll talk a little bit about the scope of the problem as far as cognitive concerns among folks with Parkinson's disease. And then we'll delve into that a little bit further as far as what those challenges could potentially look like when they initially start and what the course might be expected. And what are some risk and protective factors for cognitive decline in Parkinson's disease? And then we'll talk a little bit about treatment options, both medication or non-pharmacological interventions. So we'll go ahead and jump right in and begin by defining some of those initial terms. So first, I'd like to define cognition for those of you who might not be familiar with that term. Cognition really is just a fancy word that refers to our thinking skills. So our attentional abilities, or how quickly we can process information, or our learning and memory. All of these different thinking skills can be considered components of cognition. I'd also like to spend some time talking a little bit about the difference between mild cognitive impairment in Parkinson's disease and Parkinson's disease dementia. So the Movement Disorder Society created a couple of task forces that set out to develop standardized criteria in order to diagnose mild cognitive impairment due to Parkinson's and Parkinson's disease dementia. So with mild cognitive impairment, or PDMCI, we expect to see a gradual decline in thinking skills, and these deficits may be observed on neuropsychological testing. However, the deficits are not expected to be so severe that they interfere with somebody's functional independence. So their ability to do things like manage medications or pay their bills. And then with Parkinson's disease dementia, or PDD, we see a greater severity of cognitive decline in the setting of an established Parkinson's disease diagnosis. And here, the main difference is that these cognitive challenges are to the extent that they might interfere with functional independence beyond the challenges that motor impairments might cause or autonomic dysfunction might cause as far as how that impacts daily living. So we're thinking about just the contribution from cognitive challenges and how that might impair daily living activities. So on our next slide here, we have a nice visual representation of the spectrum that we might see in folks with Parkinson's disease. So on the lowest end of the spectrum, we have normal.
Oh, you need to share your screen, Dr. Rosen.
Oh, I'm so sorry. I apologize. Thank you for pointing that out. Hopefully we have that now. Sorry about that. I was sharing it earlier and then we stopped sharing it. So thank you for that. So here we have that spectrum that I was referring to as far as the normal cognition at the lowest end. And here we'll see normal scores on standardized testing. So maybe a neuropsychological evaluation, the scores would be considered to be within the normal range of expectation. But the individual may be reporting subjective cognitive complaints, or they may not be. With PD-MCI, this is more of a modest decline in cognition, and we have essentially normal functional activities. And then at the greatest end of severity, the Parkinson's disease dementia, that's when we start to see some challenges in functional independence. So greater attention is being paid to the non-motor symptoms of Parkinson's disease due to the impact on daily functioning and overall well-being and its relation to disease-related medical costs. So there's been a meta-analysis that looked at what the prevalence of mild cognitive impairment in Parkinson's disease is, and they estimate about 40%. So meta-analyses are really useful tools that just summarize information from a wide range of studies. And so here there's about 40% is the prevalence. Other reports range from about 20 to 41%, depending on the population that is examined. And the prevalence of PD-MCI has been associated with disease progression, specifically, as opposed to other factors like age. The average prevalence of Parkinson's disease dementia is about 30%, and about 10% of folks with Parkinson's disease may go on to develop dementia each year. But it's important to note here that the rate of progression to dementia is highly variable. So now we'll talk a little bit about some of the cognitive challenges and what the onset and course might look like. So the variability in the nature and extent of cognitive challenges among folks with Parkinson's disease is really due to the heterogeneity of the disease. So oftentimes there's a number of different domains of thinking skills that can be impacted. So here we have attention and concentration, processing speed, language, visuospatial abilities, our learning and memory, and executive functions. And we'll talk a little bit more about these specific areas as we get into some strategies that might help cope with some of these challenges. And we can also think about cognitive challenges from the perspective of single domain versus multi-domain PD-MCI. So with a single domain, we would expect 2 abnormal test scores within that particular domain. And the most common form that we see or profile that we see would be non-amnestic, which refers to not a memory syndrome, so not involving memory impairment. Within a single domain, some other domain, most commonly attention, processing speed, visuospatial abilities. And this is the most common profile observed in early Parkinson's disease. And that's differentiated from multi-domain PD-MCI, where we see impairments in multiple domains, at least 1 abnormal test score. And the prevalence of multi-domain PD-MCI is about 31% in one meta-analysis. So what to do with this information? Well, several researchers have proposed what is called a dual syndrome hypothesis in an attempt to capture the heterogeneity that's seen in cognitive challenges among folks with Parkinson's disease. So this model differentiates between 2 broad syndromes that can be characterized either by frontostriatal dysfunction or posterior cortical degeneration. So first, we'll start with the frontostriatal network dysfunction. So we can see on the left side of the screen, it's being demonstrated in this kind of region, where fronto refers to the frontal region of the brain, And striatal is referring to the striatum or the basal ganglia. And not to make it too technical, but the basal ganglia is involved in our voluntary movement control. Now, this particular syndrome, the frontostriatal network dysfunction, is thought to be due to a reduction in dopamine. So dopamine is a neurotransmitter or a chemical in our brain that sends signals. And dopamine specifically is involved in reward and motivation. Now, the specific challenges that we might see with the frontostriatal network dysfunction tend to be clustered as challenges with attention, working memory, and executive functioning. And these abilities really originate from the frontal lobes. And so it makes sense that this is being termed that frontostriatal network. Now, moving on to the posterior cortical degeneration syndrome. First, we have posterior, so that's referring to the back side of the brain, and that typically comprises the occipital lobe, which is involved in our visual processes, the parietal lobe, which is also involved in some visuospatial abilities, and the temporal lobe, which is involved in memory and verbal abilities, just kind of grossly to simplify it. And this specific subgroup is thought to be due to a decline in our cholinergic neurons. So we're experiencing a loss, not neurons, but neurotransmitters. So it may respond to cholinesterase inhibitors, which aim to increase acetylcholine in the brain. And with this particular area, what we see is challenges with language, visuospatial abilities, and memory. So that makes sense given the regions of the brain that might be implicated. So assessing what specific domains might be impaired in somebody who's experiencing Parkinson's disease is really useful as far as trying to grossly determine which syndrome they might be experiencing, because we may be able to identify an appropriate treatment intervention, whether it's a dopaminergic medication that increases dopamine or cholinergic medication. And so how can we go about delineating a cognitive profile? Well, really, this is done through a comprehensive neuropsychological evaluation. So neuropsychological tests are often paper, pencil, question, answer tests that have been standardized. So what that means is they're administered to a wide variety of individuals that are thought to be representative of the general population. And they may administer the test also to folks in special groups. So maybe people who have already a confirmed diagnosis of a dementia, or maybe a traumatic brain injury. And these groups are important because they allow us to make comparisons. So once somebody has completed the test, their results are scored and then compared to other people similar to them that are believed to be cognitively healthy, or perhaps a special comparison group, like a dementia group. And this helps us to determine where a specific individual falls as far as their performance relative to the population. So are they performing average, where we would expect them to be, or maybe they're above average or below average? But it's important to also compare folks to themselves. So we're making inter-individual comparisons and intra-individual comparisons. So when we compare someone to themselves, we try to determine what their level of functioning was before the onset of disease or some type of injury that may have impacted their brain. And we often refer to this as baseline functioning or pre-morbid ability. And that helps us to determine not only how does this person compare to other folks that are similar to them, but how do they compare to themselves? And it's important to note here that when we observe declines in test scores, we then try to determine what that might be due to. And certainly it may be due to a disease process, but it's also important to note that there are a number of different factors that can impact test performance, including fatigue or mood. Motor abilities can impact performance. So it's something that the neuropsychologist then has to use their discretion to try to figure out what degree these factors may be at play as far as explaining the test scores, in addition to other factors such as Parkinson's disease or Alzheimer's dementia. So as far as the onset and course of cognitive challenges, there may be some subtle cognitive changes present before somebody is diagnosed with Parkinson's disease. And in these cases, it's really important to continually evaluate these individuals over time, because subjective cognitive changes may predict a later development of MCI. In one study, it was over a 2-year follow-up of new onset Parkinson's. And cognitive challenges typically don't rise to the threshold of PD-MCI or PDD until after at least a year of an established Parkinson's diagnosis. So if there's a cognitive disorder that's being diagnosed at the time of a Parkinson's disease diagnosis or before a Parkinson's diagnosis, it might suggest that some other disease process like Lewy body dementia. So the timeline, the onset and course is an important part in determining what exactly might be going on. And then the incidence estimates of PD-MCI and PDD increase over the course of the disease, and we'll see on the next slide here. So here we have a nice graph, and this data comes from one study by Piggott and colleagues in 2015. They looked at 141 patients with Parkinson's disease. They had that diagnosis for at least 1 year, and their cognition was considered to be normal at baseline. But it's also important to note here that the average length of diagnosis at the time folks entered the study was about 5 years. So what is this graph showing us? Well, if we look at the top blue line, it's showing that 8.5% of the sample demonstrated some type of cognitive impairment after 1 year follow-up, and 47.4% demonstrated some type of cognitive impairment at year 6. So about half the patients that had a well-established diagnosis of Parkinson's disease and normal cognition when they entered the study developed some type of cognitive impairment within 6 years of the initial visit. So at that 6-year mark, we're thinking the average length of diagnosis at that time would have been about 11 years into the disease, since they had about 5 years of a diagnosis at the time of the study initiation. So what can we do exactly, or what puts us at risk for developing cognitive challenges in Parkinson's disease? So researchers have identified risk factors that might increase the incidence or the rate of progression of cognitive impairment among folks with Parkinson's disease. And some of these factors might be non-modifiable. So they're really, for all intents and purposes, are out of our control. We can't change them. But there are other factors that are modifiable. So some examples of non-modifiable risk factors would be biological factors like sex or genetics. But for this presentation, we're going to focus primarily on those factors that are to some extent modifiable. And keep in mind that this is not an exhaustive list here, but just some of the highlights. So first we have mood disorders. And they've been found to be associated with increased risk of cognitive decline among folks with Parkinson's. And even though mood disorders might be a direct result of the pathophysiological process of Parkinson's disease and changes in brain chemistry, there are a number of proactive behaviors that we can engage in to delay the onset of depression and then to treat it if there is a diagnosable depression. So engaging in pleasurable activities, socializing, and staying active are all important aspects of managing mood. And as far as some formalized treatments go, there are a lot of different medications out there that can be used to treat depression, as well as psychotherapy or some kind of combination of the two. And we may also be able to prevent, delay, or treat cardiovascular risk factors. So for example, high blood pressure, obesity, or high cholesterol, which have been found to increase risk for cognitive decline. And when we look at traumatic brain injury, we want to think both about the history of traumatic brain injury, but also the potential for future traumatic brain injury. So as far as history goes, research suggests that mild to moderate traumatic brain injury may lead to greater cognitive decline over time in folks with Parkinson's disease. So this would have been a history of already having had a brain injury. But risk for future head injury may be higher among folks with Parkinson's disease due to the fall risk as a consequence of the motor and gait and balance changes that folks might experience. So research suggests that nearly half of all TBI-related hospitalizations are due to falls. And so it's important to think about involving occupational therapy and physical therapy to determine mobility needs so that we can really reduce the risk of falls and possible head injury. Pesticide exposure is another factor that's thought to increase risk for cognitive decline. However, research does suggest this may be related to specific Parkinson's disease genotypes. But overall, if you can avoid any type of pesticide exposure, that would probably be the best. And then tobacco. So nicotine has been found to be protective against future development of Parkinson's disease. But a meta-analysis did find that tobacco smoking did increase risk for cognitive decline among folks with Parkinson's disease. So something to also take into consideration. So now let's talk a little bit about protective factors. So protective factors really reduce the likelihood of negative outcomes, or they offset some of the impact of risk factors. So the two main protective factors that I'd like to highlight today are exercise and diet. So exercise in general, among healthy older adults has been found to be related to lower likelihood of cognitive decline. And then when we look at folks with Parkinson's specifically, we do see improvements in thinking skills like executive functioning, working memory, and attention among folks with Parkinson's disease. So this underscores, the importance of engaging in exercise, and folks might also want to consider the timing of the exercise, the frequency and intensity, and they're still doing research as to what the best characteristics might be for folks with Parkinson's disease. As far as diet goes, the Mediterranean diet has found to help improve cognition among folks with Parkinson's disease. So Mediterranean diet really emphasizes plant-based foods, healthy fats like fruits and veggies and whole grains, and olive oil is the main source of fat in a Mediterranean diet. But I should note here that there is a question as to whether there's a direct effect of the Mediterranean diet on cognition, or if it's more of a secondary effect, because it has also been found to reduce vascular risk factors like high blood pressure, and it has anti-inflammatory effects. So we also have vitamin D levels. So there is a positive association between vitamin D and cognition. So this suggests that cognition and vitamin D levels would increase and decrease together. So the higher the level of vitamin D, the better cognitive performance. The lower level of vitamin D, a lower level of cognitive performance. But there is some research that has found no relationship between the two. So something to keep in mind and continuing to be researched. And then the last aspect of diet that we have here is caffeine. So research suggests an inverse association between coffee and cognition. So cognition appears to be greater or in folks who are drinking more caffeine. All righty. So now we'll jump into kind of the meat of the presentation here. How do we go about treating cognitive challenges? So oftentimes the first line of intervention is managing those lifestyle factors that we already talked about, diet, exercise, mood, and thinking about maybe potentially reversible factors. So are there some other factors that could be treated and we may see an improvement in cognition? But there are some medications that can help manage some symptoms and other lines of treatment like cognitive rehabilitation. So as far as the pharmacological treatments go, I don't want to get into too much detail here, but the important takeaways are that even though there are no disease-modifying medications for PD, MCI, or PDD, there are medications that can help manage cognitive symptoms. So right now, there's only one FDA and EMA approved medication for PDD. So the FDA is the Food and Drug Administration, and the EMA is the European Medicines Agency. And that drug is rivastigmine, and it's the only approved drug for the treatment of PDD right now. Other drugs are being used on an experimental basis, so there's still research being done, or they might be being used off-label. So it's a drug that's been approved for another condition, and it's being used off-label to treat a condition that it hasn't been approved for. So some of the main class of medications that we see act on the acetylcholine neurotransmitter, but there are some other medications that act on dopamine and NMDA receptors. So just for folks' awareness and information. So now let's talk a little bit about the cognitive interventions. So these interventions can be grouped into three different categories: just general cognitive stimulation, which is nonspecific and involves cognition and social functioning, like engaging patients in general activities. These types of interventions are just termed cognitive stimulation. And then we have cognitive training and cognitive rehabilitation. So cognitive training can really be thought of as more of a remediation or restoration of lost functioning and thinking skills. So it can target specific areas or multiple domains, but it involves standardized computer tasks or paper pencil tasks that are completed in like a drill-like repetitive fashion over time. And it's thought to improve different areas of thinking skills. So there was a recent systemic review looking at the effectiveness of cognitive training in folks with Parkinson's disease. And the review found that global cognition was not significantly improved by engaging in these types of tasks. But the evidence did favor improvements in the areas of attention and verbal memory, but the findings were somewhat inconsistent. They lacked strength. Now, this is in contrast to cognitive rehabilitation, which is more of a compensatory approach. So rather than engaging in drill-like tasks, we're providing compensatory tools and strategies to help overcome areas of cognitive challenge. So it's kind of like a prosthetic, so to speak, such as somebody who may have lost a limb has a prosthetic. Somebody who might be having challenges with thinking skills may rely on tools in their environment as a prosthetic to help bolster their cognition. So some preliminary evidence looking at cognitive rehabilitation among folks with Parkinson's disease has found it to be superior to treatment as usual, and has resulted in improved outcomes. And it's also been found to be effective for Alzheimer's and related dementias, TBI, and stroke. And lastly here, what I want to note is that there are components of cognitive training, so the drill type training and compensatory training that are considered part of the practice standards for treating certain conditions and certain areas of impairment. So now we'll do a quick little lesson on some different areas of thinking skills that I introduced earlier on, and then we'll talk about some strategies on how to overcome challenges in those areas. And I'm just keeping an eye on the time. We've got about 10 minutes until we want to open it up for questions. So I apologize if we have to rush through this a little bit, but we'll do our best. So what is attention? Attention can be divided into basic attention and complex attention, with basic attention being focusing on something for a brief period of time, and complex attention can be sustained attention or dividing our attention to two tasks simultaneously, like multitasking and so on. Attention is so important for all of our other cognitive skills. So it's really considered the foundation or building block. So oftentimes when folks report challenges with memory, the real culprit tends to be attention. So for example, going into a room and forgetting why, or forgetting a conversation that was had, or forgetting names. So these are often due to attentional problems as opposed to a frank memory deficit. As far as processing efficiency, this is how quickly we receive, process, and respond to information that's incoming from the environment. And reduced processing efficiency can impact our ability to socialize. We may not process conversations as quickly. It might make it difficult to follow along with a plot of a story on television, or it might make learning new information more challenging. So now we'll talk a little bit about the LEAP principles as strategies to overcome challenges in attention and processing efficiency, specifically for folks who might be having challenges following along with conversations. So this is a group of strategies that I'm a fan of, so I like to introduce this, but there are a lot of other options as well. So LEAP is an acronym that stands for a number of different strategies. So the first letter each refers to a different strategy. So first we have the L, which is listen actively. So in order to listen actively, we need to maintain eye contact with the speaker, face the speaker, and maintain open body language and posture. So this really ensures that we're setting ourselves up for success in a conversation. So if I'm not looking at somebody, maybe, you know, I'm distracted, you know, we really got to give our full attention in order to set ourselves up for success in processing what's going to be said next. The E in LEAP stands for eliminate distractions. So our brain is processing a lot of information at any given time. And if there's a lot of distractions in the environment, that's additional mental energy that our brain has to use to filter that out, to attend to what someone might be saying. So because of that, you might want to eliminate distractions like turning off your cell phone or closing the door in order to just maximize your cognitive efficiency. The A stands for ask questions. So if for somebody who experiences slow processing speed or variable attention, asking questions or clarification is a way to not only stay actively engaged in the conversation, but to have the speaker just repeat information or explain it in a different way to make sure that you heard it correctly. And then the last letter here for P, we have paraphrase. And this is just repeating information back in your own words. And this ensures that you've heard it correctly. And if not, it allows the speaker the opportunity to correct you. And in fact, paraphrasing is another strategy we'll talk a little bit about later on as far as rehearsal, because we're actually repeating it again, and that's going to help encode the information a little bit more deeply into our memory. So now we're going to talk a little bit about memory. So when we think about memory, we also are thinking about information progressing through several stages. So first, we have to be paying attention, as we talked about earlier. Then encoding involves sending information to different brain regions that are responsible for memory storage. And then when we store information, this is the process by which information is consolidated and stored. And retrieval is searching for and retrieving that information at a later point in time. Just so you guys have an idea that the strategies that we offer for memory challenges primarily focus on encoding and retrieval because we don't really have any active control over the storage component. So we have internal and external memory strategies. So the external strategies are tools in our environment, whereas internal strategies are those, they're mental strategies that we deliberately use to enhance and support our cognition. So just thinking about those distinctions as we go through some strategies here. So we have so many tools these days in our environment to help us maximize our cognitive efficiency, and I'm a really big advocate of using these tools. So a couple of the two main ones that I myself and probably a lot of people may already be using are calendars and writing things down. So calendars help us rely less on our memory and provide a record of what's happened in the past and what's coming up in the future. And so when we are thinking about calendars, we can think about paper calendars versus electronic calendars. But regardless of what you choose that works best for you, it's important to try to find a tool that you can keep with you at all times and something that you can check on a regular basis. Ideally, you'll be checking it multiple times a day. So you'll want to create a routine for checking your calendar in order to maximize its efficiency for you. And then similarly, as far as writing things down, taking notes is helping us to encode information on a deeper level. So we're making these memories 3 times as strong. And I like this phrase here, ink it, don't think it. So sometimes people have this misperception that writing things down is cheating. Shouldn't I be able to remember this information? But really, it helps us. It's a safeguard, right? If our memory is not very reliable, then if we've written it down, we'll for sure be able to remember that later. So there's really no shame in using these tools to support your cognition. So quickly here, some additional external strategies folks are probably already using. We have alarms and reminders to remember must-do items or time-sensitive activities, voice recorders. So for those who might have challenges writing down information, that can sometimes be a byproduct of the motor challenges that come along with Parkinson's disease. They have a lot of really great adaptive technologies such as voice to text technologies that will translate spoken word into a visual text. So you might be able to think about something like that, or just recording an old-fashioned voice memo. We can use automated or computerized prompts for billing or remembering a recurring event like watering the plants. Our GPS system these days can help us navigate unfamiliar environments, and we can always text or email ourselves an important reminder, and that way we'll be sure to get it. We also have some visual cues like sticky notes, putting something by the door, like a can't miss reminder as you walk out of the door in the morning, and setting up your environment. So creating a personal home for your keys, your wallet, maybe your glasses, and keeping that in a highly visual place so that you see it when you come and go from your home. So I'm taking a look at the time. I know we're getting close, so I'll go through these quickly here, but we have some additional internal strategies specifically for encoding, and folks are probably familiar with some of these: overlearning, so rehearsing to the point that something becomes automatic; linking information with information that you already know; categorizing and chunking information. So phone numbers is a great example of chunking. It helps us remember 3 chunks as opposed to 10 individual digits. And we also have acronyms, as we've discussed, and creating a funny mental picture of something can help us remember that as well. And some internal strategies to help with retrieval. First and foremost, just relax. Stress and anxiety impact our ability to retrieve information, as well as fatigue. So if you can remember to relax, that might help you. And then some other strategies like mental retracing for folks who maybe go into a room and forget why. They may think back to, what was I doing just before this? And there's a few other here. I'll highlight the routines. So establishing a regular routine is going to make things automatic for you, and you'll be able to remember it much more easily, excuse me. And lastly, just, we don't have too much time, but a little bit about executive functions. These are just our higher order thinking skills that help us drive goal-directed behavior. And they're primarily controlled by the frontal lobes, which take up a large portion of our brain volume. And we can see here a graph depicting the many executive functions, such as planning, organizing, mental flexibility, and multitasking. These are all considered executive functions. So we've got a couple strategies here. We won't have too much time because I'd like to open it up for questions. But if folks have specific questions about executive functioning strategies, we can certainly answer those. But here's the 6-step problem-solving method. It's pretty self-explanatory as far as defining the problem, brainstorming solutions in order to ultimately select an appropriate solution and evaluate it. And then I'll just skip over this briefly. If for folks who are interested in getting connected with someone who specializes in cognitive rehabilitation, I would say the best place to start would be to schedule a neuropsychological evaluation if you have not had one already and you're experiencing changes in thinking skills. And they would likely be able to provide you with an appropriate referral. And for folks who may be veterans on this call, if you have established care at the VA, that's kind of the first step. And then you can speak with your primary care provider about getting a referral to neuropsychology or the cognitive rehabilitation service. So I think here is where we can open it up for questions. And again, I apologize that we had to rush through that last bit there. There's just so much helpful information I wanted to impart upon you all, but I'll go ahead and maybe I'll stop sharing my screen here.
And then let's deal with the questions in the chat first. And then everyone who hangs out here, we're not getting kicked off at any specific time. You'll have a chance to ask your question. All right, so looking at the chat, okay, someone had asked, is a game like Mahjong helpful to ward off cognitive impairment?
So that's a great question. I don't know that there's any specific research out there looking at the benefits of mahjong, but I would say that probably falls under that category that we talked about as cognitive stimulation. So this is just a general way to stay engaged and certainly can't hurt. So I know folks oftentimes ask about mahjong or crossword puzzles and things like that. And certainly they couldn't hurt, but I think the research is still out on that.
Another question, any thoughts about the mind diet?
So
I
I'm
guess
not
that's a
familiar.
variant of the Mediterranean diet.
Yeah, I'm not familiar with the mind diet specifically, so I'd have to look a little bit further into that. But I'm sure it sounds like this is something that's been established in some shape or form, that there may be some research out there. I'd be happy to look into that further and see if I'm able to find anything about it that is empirical research as far as what they've found.
Okay, wonderful. Can you elaborate on the specifics of cognitive rehabilitation and what is the process and who does it?
Yeah, so that's a great question. So, cognitive rehabilitation is oftentimes a neuropsychologist that would be providing that service, but there are speech therapists who have their own approach to cognitive rehabilitation as well. And typically, they may be working with folks who have cognitive impairment as well as maybe some specific speech challenge. But essentially, the process would be, as I mentioned, as far as getting connected, it's really helpful if folks have initially a neuropsychological evaluation so that the provider who is administering the cognitive rehabilitation has an idea about the cognitive skill level for that particular person. So on the more mild end, there's probably more that we can do as far as using external strategies like calendars and writing things down, but also emphasizing internal strategies. So those conscious mental strategies to bolster our cognition, like rehearsing information, engaging in association and visualization. So the internal strategies tend to be a little bit more challenging as we go along the spectrum of cognitive impairment. And depending on the extent of impairment, we may also want to include a caregiver or a loved one in the process to help reinforce information that's learned during session outside of session. So the most important part about cognitive rehabilitation is really repetition and practice with using the strategies so that they start to become automatic. And the length of cognitive rehabilitation, as far as how many sessions someone might go through, really just depends on the individual person and their goals. So that type of treatment is often very goal-oriented, where we work with the veteran or patient to identify specific areas in their daily life that they want to increase their independence. And we kind of start there, and then it's a little bit of trial and error as far as figuring out what strategies would benefit them most and how long they might be in treatment for.
All right, we have a question that came through from Carolyn Carpenter. Carolyn, would you like to unmute yourself and ask about caffeine and cognition?
Sure, thank you, Rick. I thought I heard you say there was an inverse relationship between caffeine and cognition. I may have misunderstood you, but
yes, you know what, you're absolutely correct. So I did that was my misspoken word there. So what I meant to say is there is an inverse relationship between caffeine and later developing Parkinson's disease. So with caffeine, we see a reduced likelihood of developing Parkinson's disease. And caffeine has a positive relationship with cognition. So as we drink caffeine, we may experience also improvements in thinking skills.
Yeah, and
so
that's
thank
not
you
a,
so much.
sure, that's not an invitation to go out and drink a pot of coffee, but a cup or two here and there is probably helpful.
Right. Yes. You certainly wouldn't want to probably overdo it. And of course, as with any kind of substance that has an impact on our brain in some way, we always want to think about our specific health factors and of course, consume in moderation.
Thank you.
Thank you.
Walter Muller had asked about how to connect. You said it didn't come through. Walter, could you elaborate or unmute yourself?
Sure. Thank you, Rick. The part of your presentation where you got to how to connect, your slide was just a blue box. So I don't know if you can put that up again so that the information is available.
So yes, thank you for that. I didn't actually type out the instructions. It was more verbalizing them, but I would be happy to, if you have a specific question, to try to elaborate on that for you.
I am a veteran. I'm interested in what services you have.
Wonderful. Yes. So for veterans, if you are not already established with care within the VA system, that would be the first step. So determining your eligibility, which most folks who have served active duty would be eligible, but there are more criteria on the website. But if you are already a connected veteran, and you have concerns about your cognition or thinking skills, the first best place to start would be to speak with your primary care provider and let them know about your concerns, and also explicitly let them know that you would like to have a neuropsychological evaluation, or that you'd like to be considered for cognitive rehabilitation, and they can place the appropriate referral for you.
Okay, thanks.
You're welcome.
So let's open it up to any other questions that you in the studio audience may have. Just remember to unmute yourself and ask.
So I'm curious. I don't drink coffee or have caffeine in my diet. Would you recommend starting to incorporate it?
So if you are ever considering making dietary changes or any changes to like an exercise regimen, my recommendation would be to speak with your primary care provider, because everybody has a whole host of potential factors relevant to their specific situation. And so I don't like to advise on specifics related to that. For some, caffeine may not be beneficial. So if you don't drink caffeine and are thinking about doing so, you may want to speak with your primary care provider about that.
Thank you.
Mm-hmm.
All right, other questions? Just remember to unmute yourself and ask.
I had a question. Without taking the assessment, is there a way to determine if your cognitive impairment is due to PD or just getting older? I mean, let's face it, most of us are probably not spring chickens, and it's a natural process with aging to slow down a little bit.
Yes, that's a great question. So our brain does change naturally as we age, with some areas becoming a little bit less efficient, but there are also areas that become more efficient. So for example, our vocabulary expands as we age. And there's a good old saying, older is wiser. So we do have more knowledge base as we age. But really, the only way to differentiate between what might be considered natural aging versus something that might be more than natural aging would be to have that standardized assessment where then your scores could be compared to other people in your age and educational background. Because then if you're for some reason not falling where we would expect you to be, once we make those comparisons, then we can say, well, relative to other healthy adults in this age group, your thinking is below that or above that even. So really that would be the best way to determine what's beyond natural aging.
Thank you.
Mhm.
Dr. Rosen, your slide deck had just a wealth of valuable information. Is there a way that we could get a PDF of it and post it to our website?
Absolutely. So I would love to send that along to you when we conclude this, and that way folks have access to some of those last couple of slides with some additional strategies. And yes, I'd be happy to answer any other questions that come up related to this presentation, and can send along my email address for those questions if that would be helpful.
All right, would that be good or okay to post in the video that we upload, your email address?
Yes, I think that should be fine.
Okay, great. So this brings us to it's 1 o'clock. We try to end on time. Are there any final questions before we conclude today's Lunch and Learn? All right, folks, we're going to post this video up to our YouTube channel. Generally, we do this within 48 hours. If you subscribe to our YouTube channel, you'll be notified automatically, but otherwise you can find that link on our website or by going to YouTube. So I want to thank Dr. Rosen and all of you who stayed for this presentation.
Thank you.
Thank you so much for having me. It was a pleasure.
Well, thank you
Thanks
very much. That then concludes our Lunch and Learn for today. And remember, if you have any questions and you don't remember how to reach Dr. Rosen, email me, rick.stevens@pnmd.net. I'll always reply. Thanks again, and thank you, Dr. Rosen.